Yes.
Right in here.
I've been thinking this one.
So Dr. Albin and Dr. Love did leave KU around 1:47, so hopefully we'll be here shortly. We have 17 people who are supposed to be here, so we might start late. Some people might not show through the snow, so we will see.
Fair.
Okay, but there are refreshments and some snacks if anybody would like. Okay, I go back to the front.
Were you at KU this morning?
I had clinic this morning, so I just caught the rounds virtually over the lunch.
Oh, okay, yeah,
Yeah, I didn't get a chance to see it at all. I had full
it was good.
clinic. Yeah, I've heard Dr. Albin's like headlined the whole thing.
Oh, yeah.
Just the other day, like last week or something.
Okay.
We've got a virtual.
Right here? Yep.
You're just gonna be in here.
So I mean, if we end up wanting a visual, we can share some of my slides, but I prefer conversational
That's
style.
fine. Just let me know if
Sure.
that is the case. We're gonna set up.
Hello, everyone.
Hi.
How's it going?
It's going. It's going.
You didn't know you were gonna get the coldest.
Well, you know, it's happening
like,
every year.
record cold.
Because where I live in Dallas, it's like 16 today, so it's not like I escaped a warm
Yeah, that
weather
is-
situation.
Oh, for Dallas.
I was texting my husband, like, you cannot let the teenagers go to school in shorts today. Like, I draw the line at less than 25 degrees. I'm not gonna let you wear shorts to school.
Probably
Well, they have school, that's.
They
that's the
did,
thing.
they
Yeah.
did, because the roads were fine. It's just cold.
Yeah.
So there's no excuses. They've already had 2 snow days this year back, what was it, the beginning of February or end of January sometime? That's what, if we really struggle in Texas, if you just get a little bit of precipitation and then it freezes, but then it melts and then it refreezes, that's where we run into all the trouble.
I lived in Houston. I'm Jay.
Hey, nice to meet you. I just spilled water on
Oh, you're
myself.
fine.
Jaclyn, I did residency in Houston.
Yeah, I did, that's where I did my fellowship, was Texas Children's
Yep.
Hospital. So, yeah, one day it was just below freezing and no one went anywhere. And I was like, oh my God, the highway's totally open today. You don't tell where everyone is.
What to do?
I loved it. I was like, yeah, this is great. But yeah, people are like, oh, it's freezing. Why are you outside?
We don't
Like,
have enough
"But it's
clothes for
not
this.
Yeah.
I know, I was over analyzing. I was like, okay, I'm gonna wear my skiing long johns. I'm gonna double layer it. It's not that cold. It's really okay.
No, like, yeah, last night, letting the dog out. It was like, oh my God, it's so cold out here.
They're
But
like, I'll meet you
I'm
back
supposed
here
to
in
go
5 minutes.
pants, fine.
Right. I know my husband that lived in Sweden for a while and said that they have a saying that there is no bad weather, only bad clothes.
Yes.
I was like, that's a good way of thinking about it.
That's absolutely true.
Okay, we can move the picture of myself.
That
That was
Now
like,
you're
Just hold
here.
this around.
that was maybe when I was more well rested than I am now. Okay.
I gotcha.
Let me.
We should pass around the snacks too for you guys.
We brought kind of like low sugar, well, minus the Punch Market pastries, but Ruby Jean sponsored our lunch today, so, and they have some lemonade and like sweetened tea.
You said Ruby Jean or
Ruby Jean.
Ruby Jean. Thank you.
Yeah.
That's awesome. I
Yeah,
love that.
Ruby Jean's juicery. I don't know if you're all familiar with Ruby Jean's, or the folks on the call. I see some head nods. But they are a local restaurant on Troost and help support the community there. And it's Black owned, and so they help train, teach, promote this healthy lifestyle type of motto. And then the other thing is that sometimes for their juicery part, they salvage produce from Canby's markets, and our students go and volunteer at Canby's markets. I know Canby's markets also helps supply some of the produce here at Children's, but Ruby Jean's does too, so it's kind of the full circle. Um,
Oh, should we go for it? Start chatting?
Yeah, if you guys want,
Yeah.
I figured I didn't know the format you wanted to leave.
Yeah, no,
but
I want to
leave
keep
up
it
to
casual,
you.
so
yeah,
I will,
Yeah.
am I in the right spot for them to be able to chime in?
So, no, you're good. It's an automatic one, so it's just gonna pick up as much as it can.
Katie, it might be helpful if she sits in one of those green or red chairs over
Like
there,
the ones at the
actually,
front?
That's what I was
Yeah.
wondering.
because
I'm
I
happy.
can see Jay and that's about it.
Oh, sorry.
Are you leaving?
You're in my knee.
Oh, wait,
Do I
so the
need
ones
to
in the front, right? Yeah, okay,
Wait,
so
this, those there? Yeah.
Yeah.
Or the.
Chadley,
green or red?
Any on this side.
This side, those.
By the
All right.
whiteboards, yeah.
Hi, Jay, okay.
Whiteboard. Green
Oh,
chair for the
those,
win.
okay.
All right.
Hey, I said.
Hello, you look alone over here in the corner
Thanks.
anyway. Okay.
Hey, Natalie, I'm gonna run out and grab more people, or are you okay to, okay, cool.
because I haven't had a chance to actually sit in on the healthcare sector, committee meetings, because it's during my clinic time. I'm really curious to know like what else is going on in the region and really start that dialogue about how can we partner, collaborate, and fulfill the mission of the committee.
Yeah.
Yeah, so I'm Jay Robertson, I'm the healthcare sector lead. And yeah, I mean, we're trying to promote physical activity, which is kind of morphed into sort of lifestyle medicine. And you know, I think the hard part has just been, collaborating. I think we've done pretty good with the medical schools, to get people involved who can affect the curriculum in the medical schools, but we're trying to add, more ancillary medical stuff. So nursing, nutrition, PA, pharmacy, all of it. So that's, I think, where we've kind of struggled to get those people to kind of join in and collaborate with us. But, yeah, between UMKC, KU, and, Kansas City University, we got some good buy-in. I think a little more from KU and UMKC for sure. Kansas City University's been, just a little bit harder. But it's worked, I think. I guess Stephanie can talk a little bit about it, but I think UMKC and KU are both really working towards that goal of more physical activity and just general lifestyle medicine as part of the curriculum.
So if maybe one discussion topic would be enhancing interprofessional engagement in
Yeah.
lifestyle medicine participation and strategy within education.
Yeah, and I think UMKC does a good job of that interprofessional collaboration part. But I just don't know how big of a piece it is for the other parts of the medical school curriculum, outside of just the true medical school curriculum. So I think that's one of the big things, questions. Thoughts.
Absolutely, we can talk about that. I mean, I think it's a little bit different everywhere,
Mhm.
and you go where there is an open window or door, and then you kind of build from that. Okay, cool. Well, I'm good. Do we want to finish everybody kind of sharing a little bit about what you do?
Sure.
Maybe I'm gonna ask you to tell me a little bit about what you do, and then tell me something that you feel like is going well, and then a pain point. Because I think that can help us decide what to talk through.
So, my name's Katie Miner, and I'm a physician. I do the lifestyle medicine elective for the UMKC School of Medicine for the last couple of years. I'm actually in the middle of the elective right now. And I've been trying to, as much as I can, help support lifestyle medicine and culinary medicine within the 3 medical schools. I graduated from KCU, and I've had my own struggles kind of trying to get a hold of them too. I get all the emails on your organization, but then obviously it falls into all the time that I have to do everything else. But I have been recently I was invited to be involved in a food as medicine group that is forming, separate from all of this. So I feel like fragmentation is part of the problem. Like it's on the, tip of everybody's mind, but there's like this little group and that little group and that little group. And so we're all have the same focus, but we don't know what each other's doing. Because there's maybe some standardization. And so that group is more on the social work side. So there's people with Mark with the Mid-America Regional Council, KC Food Hub, Food Connect, New Growth, and those sorts of things. And their purpose is to, they brought me in wanting to work with medical schools in the healthcare community. I'm the only healthcare worker there. But also focusing on policy and logistics, and then using local food and local growers too. So, so fragmentation is
Yeah.
kind of a pain point, I feel,
Yeah,
in a lot of ways.
which is not unique here.
Yeah.
Yeah.
I'm Dustin Wallace. I'm a psychologist and fully crashing this meeting.
Love it.
I work with a chronic pain team here that uses lifestyle interventions to treat young people who are disabled by chronic pain. So we use exercise, sleep, and kind of stress management interventions. And since the beginning, the physician that leads it and myself have said we need to have a better nutrition component to it. Nutrition is definitely something recognized to be a contributor to chronic pain, as well as all the other stuff you outlined at lunch today or noon rounds today. So anyway, I'm just hoping to kind of hear more about what's going on and think about how we might integrate that into our team.
Well, and I think from a psychological lens, all of these things empower the patient, and it's particularly with adolescents, key, because they're not really into what we think. So if we can make things their idea. Speaking of the adolescents, oh no, man, my patients. Anyway. Well, and I don't know, since do you want to say a bit about what you do, or do they know?
I'm trying to see who else is on the call. I don't know if everyone was on the Zoom grand rounds earlier, but my name's Marissa Love. Hello. I don't know if you can. Hello. And I am an allergist over at KU. I'm actually PEDS trained. So I did my allergy fellowship at KU, and I've spent many nights over here on PEDS rotation. So my particular interest is in food allergy, and specifically food allergy and food insecurity. And then that's how I got kind of pulled in for the culinary medicine education at KU to teach that food allergy module. And we've really kind of made it our personal goal to learn about access to food, food waste, and getting the students involved. And so I like having more people at the party with me, so the more the merrier. And yeah, I'm excited about this roundtable.
So the people can't see me, but I am Margaret Smith. I'm a family physician at KU, and I work with Marissa and at the University of Kansas, teaching the medical school students and hopefully soon the residents about food as medicine and culinary medicine.
Our online friends want to say hi?
I'm Brooke Sweeney. I'm the medical director of pediatric weight management here at Children's and at the center, and also MedPeds trained. So we do, yes, so we do lots of all that good stuff. So sorry I couldn't be there in person today.
Amen, Peds.
Indeed.
I know we annoy everyone else with our little fan club. Okay.
I mean, I can go. My name is Natalie Updike. I'm on the Kansas City Healthy Lifestyles Collaborative team and support our sectors in our Kansas City physical activity plan.
We have a pediatric visitor.
Yeah, hey, my name is Andrew Donaldson. I'm the sports medicine fellow at Children's Mercy. I work with Dr. Robertson, and I have a very needy baby at this exact moment. So my camera will be off, and I'll be trying to listen as best as I can.
We enjoy seeing the cute little hair fluff we have going on right now. Okay.
I'm Laura. I'm Laura Tapp-Patty. I'm Associate Dean for Medical Education on the Wichita campus for KU, and working with Dr. Love and development of the Certificate of Distinction in Lifestyle Medicine. So very interested in everything happening today.
Hi, I'm Stephanie Ellison. I'm an Associate Dean of Learning Initiatives, so I coordinate interprofessional education. So I heard the words, piqued my interest for sure. I was already interested attending anyway. I'm also responsible for community engagement. And so what I love is the examples you gave just do such a great job at interprofessionally collaborating in community settings to make big ends for our patients. I've also established a food pantry at our School of Medicine that serves all 4 professional schools. So we have all 4 professional schools on one city block, which is really wonderful. But we had a lot of food insecurity just within our own program. And then I consulted and helped set up the One World Pantry, which serves University Health or Truman across the street from children. So you are speaking my language. You've got my curriculum juices flowing. I'm so excited to hear more about your program and engaging with these great people today.
Thank you. Any other online friends that want to say hi? Okay, cool. We'll pop in at any time. Oh, yeah.
Sorry, I came in late. I went to another building. But I'm Geeta Kamath. I'm a internist, internal medicine associate professor in the UH Weight Management Clinic. I'm certified in obesity and lifestyle medicine. So I loved what you said, being to the lifestyle conferences and working with them closely. I've just started sharing medical appointments. Dr. Miner here is my partner in some of these activities. She's certified in culinary medicine, and then Dr. Ellison, who just introduced herself, is very supportive of all our initiatives. And we got the bronze, whatever you call it, approval from Lifestyle Medicine for our medical education curriculum in the GME program this year. And looking forward to anything as resources. It was a great talk.
Thank you. Thank you. Well, happy to take this wherever, but I think bringing all of you together is probably the most useful part of this time, because I think you have so much momentum already and so many people that are interested. I think it's the siloing and nobody has time to sit down and take inventory of who's doing what, which I think is part of the challenge. How do you consolidate and synergize and not reinvent the wheel is key. And then really, I think the sustainability piece is huge. And so I'll just briefly give an overview of we started in the education space because frankly, that's often the easiest place to be. They're always looking for enthusiastic people to engage medical learners. And I think I was originally asked to teach nutrition about 11 years ago because I brought my lunch to work and they were reforming the medical school curriculum and they were doing a wellness week and there was exercise week and nutrition week. And they were like, hey, Jaclyn, this is a room full of internists. You're the only one of us who brings your own lunch and it looks healthy. And we think you could talk about that to the medical students. And I was like, okay. And then it started reading and I discovered some literature that was very kind of early days at the time around, hey, what if you use a kitchen to teach this? And so found one on campus. I paid for it for 4 years. And I have still not secured financial support for the medical student elective of note. And I think it's important to say that in the midst of the other successes, that I have millions of dollars of grant funding for research, but I can't get the medical school to give us $1,000 a year to buy the food, So I think you decide where you're going to go. So I actually started with a medical student elective that served about 80 students a year, which didn't even meet demand. So we ran ran more than one cohort. And then we cut it from a year-long elective to a semester-long elective. This just meets once a month for specifically culinary medicine, but we're weaving in lifestyle medicine concepts, stress reduction, avoiding risky substances, movements, just really comes into conversations about food. And then I started to reduce how much we were doing because I realized that no one was ever actually going to support my time or resources. And so we leave it at a pain point of way more interest than we can accommodate. And then we means me and one dietitian who's been doing this with me from the beginning. We don't have administrative staff or supports. And we are the program, the two of us. Now, then I started to get asked to do this at GME. And this was about 6 years ago. It's like, oh, yes, here's how much it costs. And they said yes. And I was shocked. And I was like, oh, people will actually pay if you tell them it's not free. And so we started doing this for family medicine residents first. And now it is deeply integrated into their program where they get 12 classes across their 3 years of training, one each quarter, so 4 per year. And we teach the same class 3 times to get the whole residency program. It's built into their academic half day. I charge a flat rate regardless of how many people show up, and it covers the food, my dietitian's time that I pay her bosses for. I pay a stipend to our 1970 clinical nutrition lab that we use on campus. And then it helps cover the cost of the curriculum that we license as a guide. Still doesn't entirely protect my time, but I'm able to work it out because I have some research time and I have some APD time. And it's just like, robbing Peter to pay Paul with time, which is true for everyone I know. So then we started to build that, and the learners were like, okay, I'm ready to do it with patients. It's like, oh, I guess we could do it with patients. And so building the clinical model is ultimately where we got momentum in the health system, and people started paying more attention. So, I mean, I talked a little bit about it, so I'm not going to describe more unless we have specific questions, but basically using both one-on-one coaching consults that are physician dietitian collaborative, and then doing shared medical appointments with patients that are physician dietitian co-led. And then letting basically everyone who wants to be part of the program come to resident and student classes. So I'm very choosy about who volunteers at the patient classes because that's a different skill level to be successful. But anybody in the health system or community who emails me out of the blue and says, I'm curious about this culinary medicine thing, I will let them show up and wash dishes. And we run about 80 classes a year, so we're able to find time for people to come. And before you know it, it's like there's this trickle effect. And one of the recent examples of success that we had was I had been working for a long time to try to get local farmers were coming to me saying, why can't the university buy produce from us? And I'm like, oh, I don't know. Why can't they? And so started asking questions, and people said it was impossible and it wasn't going to work. And then years later, I found the right chef who was willing to figure out that all you had to do was make the local growers a contractor with the food company that we use, and then you can order, they can buy their food. And so now we source almost entirely local growers, so I think little problems like that are often just about the right person and not accepting no for an answer. But sometimes you don't have time to chase the rabbit, so it takes years. And so I think identifying like where the pain points are, and then where do you overcome and in what order. And I think my biggest success and stress reduction was relinquishing control as if I had any over the process and just letting it unfold a bit and being ready when someone was interested. And so the last thing I'll say from the research side is I am not an independent investigator. I have never wanted to be an independent investigator. I have NIH funding as a co-investigator, and I'm only PI on philanthropic or foundation-based grants. And I partner with some really talented independent investigators who I write grants with. So getting the research money has been huge, whether it's philanthropic, foundation, or NIH-based, but anybody doing the work does not have to be the one that knows how to do all the things. And I think the more we can find people to synergize with, the more effective, because we need good science in the space, both educational science and patient care assessment and how we're doing this. And then lastly, our pediatric GI clinic runs our obesity program at Children's in Dallas. And I was approached by a junior faculty member about a year and a half ago who said, could we do this in pediatric obesity clinic? I was like, sure. We just need to find a kitchen space near the children's hospital or near the community you're trying to do it with. And we already have a model in place. And so, I mean, it's a process, right? We had to write the business proposal. I went with her to her division director and said, will you protect a little bit of her time to figure this out? And then she can make this part of her clinical time to run shared medical appointments. And then we pitched it to the health system, CMO, and we're beginning to get traction. But it takes a while to build these things. But I think the key is recognize there's people everywhere who want to do it. It's a win for everyone when part of their clinical practice allows for not only interprofessional collaboration, but also doing something unique in patient care. I'm curious, is anyone doing school-based interventions from the PED side?
No, I don't think so. As far as nutrition, no.
Yeah.
I mean,
or physical activity, any of it. Yeah.
no, I
stress
mean,
management.
we've tried to get some school-based health stuff going on at Children's Mercy, and it's been many years of thinking about it.
Yeah.
Actual progress. But that's been lots of hurdles. People have left, COVID happened.
Yeah.
When I thought we were getting some momentum.
We have not cracked the nut either. I think the state with the most success there is South Carolina. And they have a school-based wellness initiative, but again, it comes with funding, right? So you get funding for something, you can often find a way to make it happen. And they incentivize schools to do healthy lifestyle programs. And they're in competition with each other in the district. And then the schools that win the prize get more money for investing in their programs for the following year. So it creates this like healthy competition concept, which I've found to be a effective strategy, even though we haven't quite figured out how to do it in Dallas either. There's a lot there, and the schools are
Politics, I imagine too.
Yeah. Okay, so what things do we want to dive deeper on?
I had a question. You said you have about 80 in each class. These are residents, students, patients.
So our student and resident classes are typically separate, although we have student volunteers at everything. So that is another way that if students who can't make it into our elective, I let them come volunteer, and they kind of get exposure through that. So our student classes are mostly medical students, although it's open to PA, PT students, and then we use our clinical dietitian students as sort of peer facilitators, and they work as interns under my dietitian co-lead. And then really we've struggled to engage, you mentioned other groups like pharmacy and such, but on the pharmacists very much want to be engaged, has been my experience. We're doing a little bit of a research project with our pharmacists where we're using them to distribute nutrition resource information with prescriptions in the county system. So we created like a zip code based flyer that tells people about here's a basic healthy nutrition website. How do you find out about SNAP benefits and who's eligible? What is your local food pantry that we recommend in this zip code? And then they can opt in to give feedback about what they want the health system to do to support them. And we are measuring uptake by QR codes. And we're experimenting with using our mail order pharmacy versus a brick and mortar pharmacy versus our clinical pharmacist handing it directly to a patient to see what uptake looks like. But the pharmacists are obsessed with this because they want to be a resource for these things. And I think the University of Maryland has been the most successful in having true interprofessional across 5 or 6 health professions in the same culinary medicine class. They've published their work, and they have all the students working together, because there's nothing like leveling the playing field when everyone's in the kitchen cooking food and talking about its role in health, and there's no hierarchies. And I think it really works well with like fellows and faculty working together. So I think it breaks down some of the silos when people are all in a kitchen together, for sure. And it doesn't have to be a fancy kitchen. None of my kitchens are fancy at all. We have no beautiful health system kitchen.
I cooked at a group on a tiny little table with a blender, that was my little pop-up kitchen, was really like this big.
iPhone, you could put an iPhone.
Yeah.
During the pandemic, we would take a cabinet like that, and then you screw in one of the things that holds an iPhone or an iPad, and you're literally just doing it in your own kitchen. There's actually the Teaching Kitchen Collaborative internationally they have a lot of webinars. I think it's like $99 a year to be a member to get access to all their webinars. And they talk about all the different kitchen types that people do pop-ups. Ours are hands-on, but they are stainless steel tables in many cases where we're bringing in burner units, and where, again, the medical student volunteers are helping set all of it up and then popping up a full kitchen station for each group. Because I think the more involved people are, the more engaged they become. Like if they can get hands-on, that's ideal, but you have to work your way to that.
So Katie did help in my shared medical appointment.
Yeah.
I started last year. I have had the first cohort.
Awesome.
And one of the patients, actually, that's why I asked you the question earlier in the backgrounds, wanted to come back this year. And I didn't know if insurance allows her to come back.
We don't know either. But we did have one patient who tried to sign up 3 times now, and we're like, we will try to create maybe a upgraded level 2 class series next when we have more capacity. Right now, the way we're handling it is this summer, we're gonna trial doing booster classes for anyone who's graduated as like a follow-up appointment. I mean, I think they're all being billed from an insurance standpoint. It's coming in as like a B&M code for your hypertension, your diabetes, whatever. How many times can you see your doctor in a year about that problem? I don't know. Do they put a limit on it? I mean, it's hard to say. So I think it's that we're still figuring all that out. Everybody's figuring that out.
And the other question I had was, I'm not certified in culinary medicine, and Katie is. She came for several of the sessions and was able to do no cooking demo because, again, like she said, we had to do a pop-up showcase. It's what you could put together, and they loved it. But can somebody who's not certified in culinary medicine still, do these sessions when she's not available, or if
I mean, I don't think there's any requirement out there from anyone. I do think if you're billing health insurance, there needs to be a certain level of like culinary skill and literacy to confidently be able to teach it to patients, but there's no rules about this. I think it's a great way to bring in, I mean, in general, to run a true culinary medicine experience, you need somebody with some nutrition knowledge, somebody with medical knowledge, and somebody with some culinary knowledge, and that could be spread out among physician, dietitian, PA. Some people use local culinary interns who are very interested in being involved. And I've had a couple of classes that I had to run without my dietitian, and I invited our health system chefs, and I said, I want you to come and demo your favorite thing that you like to cook and just talk about it. And they don't necessarily have a ton of nutrition knowledge, but we were able to say what the skill in cooking food at home is really what's the barrier for a lot of people. They have to figure out how to make it faster. They have to realize it's not as expensive as they think to prepare food at home. And if it's accessible to them, they now feel empowered to do it because they learned how to make it taste good, then it's easier to sustain. And so I think that culinary knowledge, you don't have to have high level expertise, but when you do bring in an expert, it lands for patients in a way that me doing it as a mediocre cook is not gonna land.
I just add to that, just because one thing that I learned that I decided to do, just because it was what I do also give culinary classes at the Mid-Continent Public Library, and what they required was a food handler's permit.
Yes, somebody on the team has to have that.
Somebody on the team, so I got that, and within the Kansas City, you definitely have to have the Kansas City one, so that would just be another thing that I would.
Oh, that's a good point. It's not expensive. It's an
not
online
expensive.
class.
Yeah.
In most places. And actually we get a bunch of our medical students to get that. And then they can do demos at food pantries or in the community setting. Medical students, in my experience, very much want to be out there engaging. They want to make what they're learning feel real. And I'm sure other health professional learners are similar. And so giving them empowerment to do things and then making sure they have the right resources so they can support it, I think is a really good strategy to build capacity. There's Tim Harlan, who runs the American College of Culinary Medicine, always says medical students are the force multiplier. Like they will take a very small program and help you do more. And then thinking about I always have other types of learners come to me and say, well, what about me? I'm like, yes, you're invited. Everyone is invited. There's room for everyone to be part of it. Yeah.
And I will say, I'm not sure if you're all familiar, but Robin Shook, who is here, he gave, and Deb Sullivan, who helped design your kitchen just down the hallway here. I don't know if you guys knew that there's a kitchen like right around the corner here. There's a teaching kitchen here.
We should go take a tour.
That Sullivan designed, and so we took a tour of it because we wanted to figure out a way for the Center of Children Healthy Lifestyles and Nutrition to do something collaborative between KU and CMH and UMKC, and so we took a tour to see if that was even feasible. There were some things that he had to update, but from what last I heard, I think it's ready to be rented out for a culinary class. So you have that here. Like you don't have to go very far for it. And people, at least Robin said that he wants you all to use it. And then in addition, you have a chef educator here. So I don't know if you're familiar with Rachel Finn, but Rachel Finn is your chef educator and dietitian who does a lot of metabolics work. And she is the daughter of Dr. Mani Mani, who used to have this, I forget the name of the restaurant, but it was like this famous restaurant in Shawnee. And so she grew up cooking and she's wonderful. So we have a Chef Rachel as well, but she's Chef Rachel Chordash, and you all have Chef Rachel Finn. And I wish they were on, but they were on the Grand Rounds talk earlier. But happy to connect you all because you have that here.
And generally speaking, I think everyone in medicine, they feel like they have their lane and they're really touchy about crossing over. But this is relevant to everyone, right? Everybody eats, everyone cares about food. We all want to be healthier. The problem is so big, there is no need to be territorial about having space for everyone to participate. So I think that's the key piece here is how do we make everyone feel like their voice matters and that you don't have to have expertise to show up and wash dishes and support the community. And you don't have to have expertise to begin experimenting with doing group events. And so I think then over time, a lot of the learning is like from messing up. And then to speak to psychology, in our one-on-one clinic where we're meeting, I meet with patients first and bill, and then it gives them access to my dietitian. And most of these patients have never had access to a dietitian before. There is about half of the patients are emotionally distraught at some point because they are sharing about, I have people share about childhood abuse that they have never told a doctor about before because talking about food brings it out, or how they've used food to cope, or they've developed a dysfunctional relationship with food because of another trauma in their life. And when you start to dig that out, you're like, we're not going to make progress in any behavior change without cleaning out the closet, which then needs a lot of mental health support, which is beyond the scope of what I can offer. And so that people ask me, do you need another dietitian? I'm like, absolutely. But the next person we need on our team is a behavioral health expert because people need to process how complex the food relationship is when there's so much that has shaped it. And again, I was telling Dr. Love's fellows this morning that, if you don't have enough time to actually know where someone's coming from, you might actually do harm by talking about this. So sometimes the right answer is not going there today, or just saying, yes, food very much matters to your health condition. Let's follow up on that. Let's learn more about what you eat, where you access your food, what your relationship with food is. And I actually ask people that, what is your relationship with food? You learn so much from that one question because, some person will say, oh, it's very love-hate, and then they'll go into detail. And you just sit there in silence and they will tell you all kinds of things that shape the approach. And even children, it's so much to learn there. Oh, well, if I'm bad, I can't do this. Or if I'm good, food is, I get this. And we're creating a lot of relationships with food in the way that we manage food. That's why I work with parents a lot on not bargaining or using any type of food as a reward, because then you're creating this, food is, if I'm bad or good, it relates to my food. And so it creates morality. Food does not have morality at its most basic level. And so I think that's a lot to unpack, which I'm sure you do.
That happens a lot in food allergy as well, with my food allergy patients.
Here.
And so we have gone to when a person's levels have gotten so low that they're ready for a food challenge, we don't say pass or fail on the food challenge. It's tolerated or not tolerated because you don't want to put a grading to it. And many times it's and the folks here like Dr. Jones and Dr. Panzia here at Children's that manage the food allergy clinic, it's even hard to get them to eat the food because they've been told for X number of years that they can't have the food. So, what's the point of doing the food challenge if they're just going to try it once and never going to put it back into their diet? So we are definitely lacking a food allergy counselor or psychologist in the region. It's very hard to find.
And if someone has a history of disordered eating.
Yep.
That the conversation has to be approached differently. And we actually, in culinary medicine and in lifestyle medicine in general, I specifically make it not about weight. I always say it can be your goal as an individual patient that you would like to lose weight, and you can share that with me and I will support you. But I always say our goal is a healthy relationship with nutrient dense food that makes you feel better and have the energy to do the things that you care about, and hopefully also reduces disease risk. And that might be for one patient, I want to get up and down off the floor with my grandchildren. I want to feel good enough to walk around at the grocery store. You know, I ask people their why. Why are you here? Why do you want to make a change? Because by the time they get to me, I do at least have the advantage of knowing they want to make a change, or they're not showing up at this random culinary medicine clinic that they don't even know what it means. That takes bravery, right? So I have a biased sample, but I think that we don't need to spend as much energy with people who maybe aren't quite sure what their why is. They need to work that out before they're ready. Or they're so focused on weight, which I cannot make any promises that even changing to a nutrient-dense diet is going to lead to weight loss, especially in postmenopausal women, which is a big population that I serve. And so if we disassociate success from weight change, it changes the narrative. Success was you tried a new food that was nutrient dense, or success was your family liked what you made, or, you know, success is redefined. And so I think we have a lot of room to do. And yes, I would like my patients to also lose weight in many cases, but not making it about weight has been big for us.
I was curious, at each institution, is there a culinary med program already, or some kind of, I know UMKC has the residency lifestyle med?
So I just teach a twice a year, 1 month lifestyle medicine elective. And so that for the upper years, I do take some St. Joe students. And so it's very small right now. I'm working on the bandwidth to make it bigger, and would love. What?
You're 3rd and 4th years.
So it's the St. Joe campus is 3rd or 4th years, but this campus, since it's a BA MD program, we do 4th, 5th, or 6th. So usually I'm getting the 5th or 6th years. And in large part, there are a few who, like, I purposefully set aside time to take this elective because this is what I want to do. A lot of my students are like, yeah, I heard it's not, you know, as hard as orthopedic surgery or trauma surgery. And it's pretty low key and it's remote. And I'm like, yes, thank you. So I get like a psychiatry wannabe, or I had a pathology wannabe last year. So, but it's very small, you know, and there is the FAME elective, the Food is Medicine Everyday elective with at the kitchen at St. Luke's, which they can take, but it's all very elective. And that's kind of a pain point for me. What my personal pain point is my bandwidth, but I feel like
time for free.
Exactly. And but I would like to see, you know, more of it in, you know, at least UMKC, but
yeah.
And is the FAME elective through UMKC or just St. Luke's?
It's better students, it's
Yeah.
through UMKC.
Through UMKC. And
Yeah,
is
St.
it-
Luke's is an affiliate.
Okay, gotcha. And is it offered regularly? Because it's done by a dietitian, right?
Yes. And I don't know how regularly it is or how often it is, but yeah.
I think she runs a full program, Food as Medicine for patients, and then students can probably go.
I think Stephanie knows.
Yeah.
Yeah. So I used to be the associate dean for curriculum, and this leadership position was broken off to kind of manage things that were areas that needed a focus, such as IP and community engagement. And Katie's exactly right. Like with resources, it tends to be like, well, throw out an elective and see if there's traction with that. And so Food as Medicine is offered regularly, and it is true. It's because it's patient based, and then students attend and also have a greater understanding of it. I run a community engagement service learning elective, which has grown in popularity. Equal parts, what Katie said is, well, it's not real demanding, but they do have a minimum set of hours. And so what's happened is I've got to get agencies approved as sanctioned because of liability insurance. And so you found a great hook with patient care, right? Like that we can bill for it as long as we meet these three things. Well, with community engagement, I do have to get it sanctioned or it's placed in certain courses, which automatically makes it approved by the university. So we have a food security section, which is incredibly rich. It's both, pantries and dining with dignity close to the med school. And that has garnered a ton of interest by students to do a deep dive and go back even when they're not on the elective. And then we have a community garden at Children's. In fact, I don't think you can see it. It's too snowy. But if you look west of Don Chisholm, it's on the property just past their parking lot. And we use the kitchen to store a lot, and the weight management clinic used it for cooking. In fact, for the longest time, I kept saying, is there anything left for me to take to my pantry? And they're like, nope. So it went to patients for as long as we could. But the community garden is another one of those things that's sort of like a network, right? You'll meet other places like Canby's that takes additional produce and that works with families in need. So it's really about networking until you find that thing that pays for it, like patient care and insurance, that you can get it paid for. It's much harder to do it from within the system. So we have a new dean. Geetha and I work to map the different lifestyle medicine elements and within the curriculum we have. Admittedly, our curriculum management system information was already 2 years old. This was a year ago, but ACLM accepted it and said that we reached a bronze level because of the lifestyle medicine elective that both Katie and Geetha had formed, because of the interest group. And then just making movement to improve the curriculum and all of the pillars is helpful. But what I love, I agree with you completely. Culinary medicine and food touches everyone. And it tends to be less of a stronghold of like lanes and scope. It's more of a like, let's break bread and have a discussion and let's talk about it. And so Don Chisholm has helped us as a community garden. But we are building a full kitchen in the new interprofessional healthcare delivery building that's broken ground. And so that's very exciting because it's just right across the street from School of Pharmacy, School of Nursing. We're in there a little bit. It's mostly School of Dentistry, but we're catty corner. So that kitchen can be a wonderful way to offer and bring everyone together. And then cross-listing the requirement for pharmacy, you are 100% correct. They are ready to prescribe food and understand it and hand out flyers. And their community engagement is tremendous. I mean, it starts off with vaccines, but it goes through everything that they think will reach their patients. And so collaborating across professions, I think, is the power of really getting more interest. And then our deans are interested in funding interprofessional stuff. So that's the way to kind of, I think, internally get things going, especially since the space is being built. And then just bringing the cohort of faculty that have ideas and where to put it. One question I had is we've kind of touched on wellness. There are elements of wellness to this, and they're trying to improve wellness at our school. And I curriculize everything is, well, lifestyle medicine for patients and the learners is really important for them to navigate professional programs. And community engagement has always been a wellness parameter for our students who reflect on it when they do it. So that's kind of where I think it can function, as well as we have a very strong humanities department. And so finding the elements and offices that share a similar mission and then just working within them to establish programs is helpful. So for example, we did build a lifestyle medicine curriculum. Mostly myself and Geetha. Katie took a look at it as well. And then we were going to create it as a longitudinal curriculum across places where it made sense, right? Like patient physician society. There's a lot of elements to that, behavioral science and relationship to food in those courses. Do you mind just illuminating where you found room in the curriculum and then how, I mean, I know the stakeholders, but how you did that and got buy-in at the medical school, or how GME enhanced that? Because that's the one thing we haven't really merged GME as well as I'd like.
Yeah, to be clear, everything at the medical school is elective based, with the exception of the what I'll call our ambulatory rotation, which has wellness themes. Okay, so just backing that up, because that's what came first, was when it was around the time that our medical school went from a 2-year preclinical to 18 months. And because of that, they transitioned to having an additional clerkship called ambulatory, where they pulled all of the internal medicine and pediatric outpatient clinical time together onto an outpatient rotation. So they have 6-week block. That is, they do inpatient internal medicine, inpatient pediatrics clerkships, and then an ambulatory clerkship. So they have a little more time, a few half days where they're not busy. And so that was where the medical school had asked them to integrate wellness for whatever check boxes that fits, that when this was a thing across all medical schools trying to more intentionally address wellness in the learner, that was where they put it. So 1 week of nutrition, but that really translated to 3 hours. 1 week of exercise, 3 hours, right? So that was how it got split up, and all taught by voluntold faculty to come up with a curriculum and just do it on repeat every 6 weeks. So that was where we first brought in the concept of culinary medicine, and they were obsessed with it. And I actually would bring them in every 6 weeks. We would bring the whole clerkship. It was like 30 students and it was very tight, but we would bring them all to our kitchen that's much more comfortable with more like 20 students. But they said, why don't we learn this earlier? This is 3rd year at the time. And why aren't we talking about nutrition anywhere else in our curriculum? Like, they were almost mad. And I found that really reassuring after having spent a lot of time not being taken seriously. And so then we built the elective for 1st years. And now I allow 1st and 2nd years, and then some of the School of Health Professions learners to sign up. But that is all elective based for culinary medicine. We evolved our ambulatory clerkship curriculum into what we call Eat for Health, and which is the only one I have jurisdiction over. The rest of the wellness curricula, I'm not sure what they're doing. But what we ended up using is we actually have them go through some online modules that are we do purchase. They're not expensive, but they're not free. And it's through the Gaples Institute, which is run by a cardiologist. It's just a nonprofit related to education. They actually have both Spanish and English patient modules that are free online, and a lot of patient handouts. And part of the reason we picked it was we realized, I basically said, I'm not going to teach this lecture every 6 weeks forever unto eternity with absolutely no protected time. Like, I was just over it. I was doing too many other things. So me retiring and then no one able or willing to fill the role, I said, you know what? We need an externally updated tool. It's going to cost you. And my health system was quite willing to pay someone else for the resource. So we purchase, I think it's $9,000 a year for every single one of our 250 medical students per year to have a license to this. And it's about 2 to 3 hours. They get patient handouts and they take some little quizzes, and it's interactive. Then we put them in a synchronous motivational interviewing talk where they learn about how you talk about SMART goals, how do you assess behavioral change readiness. You just heard about how important this is to health, and it just touches on food insecurity. It touches on all the metabolic diseases and the general categories of food. Then they take their motivational interviewing, and then they have 2 applications, and we've published on this in the meta literature, but man, assessment is a doozy. And I actually even did a huge study using standardized patients. And the most senior statistician at our institution was looking at hundreds of assessments from the SPs. And she goes, I don't know how to tell you this, Jaclyn, but the standardized patients are not standardized when it comes to talking about food. They're all over the map. They do not know how to be objective in evaluating the students on a conversation about food in a way that is not true about other things. And I was like, oh my gosh. So I just spent all of this time and money and energy, and we have terrible data. So what we ended up doing was much less time and resource intensive. Is we give them a case, and they have to write an assessment and plan in response to the patient's case. And then we score it on some certain barriers, and like, did you assess the patient's barriers? Did you assess their strengths? Did you provide a practical advice? Did you refer to other health professionals? And we're looking at that in their progress notes. So we have a standardized case, and then we make them do the same thing with a real patient that they're encountering on the clerkship. And they turn in both of those, and that's like their product. And we've done qualitative review of and analyzing their notes. Are they hitting the objectives or the themes in the competencies that we set? So that, I hope that helps. That's our only required thing. It's probably a total of 4 hours. And that's all that, but the medical school deans will call me like, hey, we're doing nutrition required, right? Yes, thank you. Checkbox done. Like that's all they want to know. And then the elective, and then I also run a 4th-year nutrition elective that's similar to Katie's, is entirely online, and they love it because maybe they care, but they also love it's pretty. I make them turn in a lot of things, but they're learning, but it is also flexible. And maybe that's good. Maybe we're giving them a chance to explore their own wellness while exploring the topic at the same time. In the residence and fellowship curriculum, it is almost entirely required because their programs are paying for it. So they make them come and they want me to take attendance, and there's a faculty showing up at these classes. In the resident curricula, it's almost always done during academic half-day didactics that are built into the schedule. And then during the fellows, it's almost always after hours, but they still expect them all to be there. It's only, for most fellowship programs, it's twice a year.
So for the resident part during their academic time, is it just one time a year you go and take over the whole block, or is it like multiple 1 hour?
Multiple times throughout the year. So our family medicine, the way they do it is they want topic A 3 times, and that's done in a 3-month span, and then topic B 3 times in another 3-month span. So they free up 1/3 of their residents at a time for academic half day, and we do the same topic 3 times, but they each get 4 classes a year.
Okay.
They're the most rigorous. Our internal medicine program just launched kind of a community and health equity track, which is a completely separate residency within the residency. And they're going to do the same model. They're matching their first class in March. And then our fellowships, which are GI, endocrine, cardiology on peds and adult side, they mostly do 2 a year. GI, adult GI, for example, will get half their fellows free and then the other half of their fellows. And there's a couple people who come to both. And so they pick different articles on the same topic, and we do different recipes on the same topic so that it's not overly redundant, but it'll be like EOE both times, but we're looking at 2 different papers as a journal club approach, and then 2 different sets of recipes that you might recommend with your patients. And we sort of tailor the curriculum.
We will be testing.
Okay, I was like, is someone looking on the?
And you're doing recipe and basically all those resident and fellow talk.
So my culinary dietitian is the one who does this because the fee they pay me allows me to buy her time. So I'm able to buy 6 hours of her time for every class. And we're running 6 to 8 recipes at every class, entirely hands-on, station-based. We're usually 3 to 4 residents or fellows. And usually we invite all the we tell them, invite your dietitians, invite your program coordinator, invite your staff. Like we want everyone to be doing this together. And so we try to fill the spots. And they will all cook a meal together. And then they have to present it. We have a whole section we call Sell Your Dish, where you have to like have a portion size. You talk about, how do you talk to a patient about what you just made? How is this different than what they got at Taco Bell? How is this, something that a busy mom who's working 2 jobs is going to make? Where did we buy these ingredients? They're all from Walmart. How do we make everything accessible, affordable for people? And teaching them all of those practical ways to talk about food that they do not know 90% of the time.
Yeah, we took our students to one of the grocery stores, and I gave them a budget, and they had to get all of the items. It was the spaghetti module. They had to get all of the items that they needed for under $25. And it was tricky. They had to compromise and read labels and understand like where they could rinse out salt because it was canned, or if they needed frozen, if it was going to be just as much nutrient. So yeah, it's just going to the grocery store itself was eye-opening for the students.
Yeah, because they don't go there. They had college cafeteria, and then they moved into, and many of them were not taught how to cook. We do, when they've been through culinary medicine for a while, we do a challenge similar to like Health Means Food has done some of these as well. But we'll give them a box. We'll say, oh, this is a pediatric resident group. This is your WIC box. What are you making for dinner? That's it. You can use the internet. You got each other. You got all the tools. You got what's in your box. Or food pantry box. What are you making? What are you making for dinner? oh, and by the way, there's a food allergy X in the family and you have 30 minutes. And so you have to put them in the situations that the patients are in for them to stop this we know best and you just need to eat better and exercise more discussion problem that we have. Because there's so much lack of awareness of how people are actually putting food on the table for their families.
And I will say from the residents, I don't know how integrated you are with a residency, but the in-person cooking, our allergy fellows really enjoy
They
it.
love it.
And then I'll even do part wellness day where we go into the gardens and we're like, oh, we're just gonna do a wellness walk. We're gonna pick all the produce that we're gonna cook with for the students later. So our allergy fellows have really enjoyed it from that standpoint. And the Rachel Finn's boss, who is in charge of the gardens here, the community gardens here, has talked with folks in the region about how to help source that and make it fruitful for their cooking classes. So I feel like we just need to connect you to the right folks, and hopefully get some movement that way.
Well, and to Stephanie's earlier point, you know, wellness and IPE tend to be the biggest funding sources for the education side. But my health system did not take any of this seriously until we showed them this was a fundable research strategy as an approach, and also a clinical strategy. And so most of the research that we're doing is through our clinical translational science awards. So we're doing it in the community arm and then able to get pilot data to then apply for RO1s. And again, I'm not the PI on the RO1. I'm just the ideas person and the connector to the resources and the patients and the model. And then I'm getting people who are writing those grants to do it with me. And then suddenly the health system's like, oh, what additional support do you need for this? Because they're seeing that this is a win-win across lots of different programs. And I think the more you can connect all the dots and share resources, the more everybody is able to do more of this. You know, it's just hard to make it happen logistically.
Well, the other thing that I hear whenever we suggest that they add a little more education into the yearly curriculum at the resident level, med student level, whatever, is this on a test? Was how is this going to help our students pass board?
There is a huge push for it to be on exams. Huge push nationally. I think actually Harvard Food Law and Policy Clinic is driving a lot of this. And you would say, why are employers involved? But they're the ones who are actually pushing ACGME and AAMC that doctors have to know this stuff and you better put it on the exams or some, they're actually trying to get a lot of congressional representatives to threaten pulling funding, particularly CMS funding for residency training, if we don't get our act together and regulate our profession's exposure to this topic. So, I mean, there's actually a lot happening on that. I don't know if they'll actually, who knows what the current administration might make happen on this one. But I think the time in many ways is still ripe, if different, that we can continue to push for the relevancy of this. Because I always say, you don't have time not to learn about these things, you know, and the more you can sell them the win-win. We're actually working on a brochure that the American College of Culinary Medicine is very interested in, and because they're facing, everyone who's a member doing this with medical schools is facing the same funding issues. So they're like, how do we help everyone stay afloat? And so those of us who've had success with GME, they're like, ooh, let's help everyone who's already licensing curricula to say you can teach this to other groups and potentially get more funding. And so we're creating a brochure with them that's going to have a pictorial of like, hey, look at all the programs across the country who are currently doing this in GME. Look at all the residency and fellowship programs that are doing this. Look at all of the multifactorial competencies and domains this hits for your program. How can you figure out where the gaps are in your program and then checkbox it? I think ACGME is a little bit more supportive than AAMC has been, and then AACOM is probably more supportive than AMC has been. They'll all show up at the meetings, but in terms of actually moving, I think ACGME individual residency review committees are at least talking about it. And adding, I don't think we're going to see a common program requirement in the near future, but I think we may see integration into specific specialties. And then I talked about it a bit this morning. Someone's talking about ACLM. I lost that.
Board questions.
Oh, yeah. Yeah. ACLM does provide suggested board questions. It has not been integrated on exams that I know of. But I think it's on the patient's exam, right? You show up and your patients give you the test, you failed on this topic.
For sure.
So it's really about equipping them to do the patient care piece. And the sooner we get the students in the community and get them to be the voice, they're the ones telling the administration, we don't have enough of this. And every time a student complains to me, I'm like, please tell your deans, please tell your administrators, you want more, you want more, you want more. And then they have to, they're the customers. They don't really care what the faculty think.
Another thing that I thought of isn't on the test, but a question I got when I was trying to sort of lobby for the elective that I'm now teaching is like, well, what if we're going to add something, what are we going to take away?
Yes.
Because there's only so much time and space in the curriculum. So what leaves?
The students have lots of ideas there too. Like what's redundant?
Yeah.
What's overdone? What takes up too much time? What did they not get enough of? And I think anything new and different always comes with a ton of pushback. People don't like change, and especially disruptive change. And I think that we were faced, whether it's in a clinical environment or an educational environment, some things you just kind of have to do without permission and ask for forgiveness later. But in electives, anyone will almost let you teach an elective, but then you have to decide how much blood, sweat, and tears am I going to put into this before, if I don't see some progress. And I was probably close to giving up around the time the pandemic hit, because I had been teaching for 4 or 5 years with no funding of any sort, and trying to figure out how to be a faculty member and build my career. And then I don't know, just little breakthroughs that kept me from quitting. And then finally you start to see the groundswell happening of like, oh, okay, this actually matters. You get one patient who writes you a message and says, you're the first doctor who ever talked to me about this. Thank you. Or you get, one person on campus that's in a totally different space telling you that you inspired them. So I think it's just about being, and that's another thing, is like to keep the hope alive. You have to be very vocal with everyone else doing this, thanking them, supporting them, getting together, having a person or two you can call when you're about to quit, because it's always hard to do new things. But you go back to your why. I can't practice primary care the way that I was trained to practice medicine anymore in the current system. I can't do it. And actually, when I call it retired, when I retired after 10 years of MedPeds primary care, because all my clinical time is either in resident clinics or in culinary medicine now. Patients say lovely things to you that they never said to you when you were actually their doctor. But, but messages like, you're the best doctor I ever had, and things like that. And I remember one day I was really emotional about this. And I told my husband when I was processing it, I said, what's sad to me is that my choices were to continue being the best doctor this person's ever had and literally kill myself and not be there for my family, or to find a new way. And I wasn't willing to give up medicine, and I wasn't willing to give up my family, but the way that I am forced to practice medicine as a primary care physician in this country, in this system, I'm not going to do it anymore. It was killing me to be the best doctor, to answer all the messages, to navigate the system's brokenness. And so I've found joy in medicine again by doing this. And I actually think I'm making a bigger difference than I was before, because I felt so handicapped at being able to actually break through and give people the tools and resources they need. Like, they need so much more. They need so much more than we're giving them. And that's part of the joy of the interprofessional interest in this, is that if everyone has a piece of the pie and they're hearing this everywhere they go, and we get some sort of consistency in our messaging, which means we get out of the nutrition factions and we all agree that we care about fruits and vegetables, and whether or not there's chicken should not break the conversation in two, And so I think that's really key, that we focus on keeping the main thing, and helping people move towards just more food prepared at home. and that having access to food consistently. But and then I said this in grand rounds, but you also have to know who doesn't want you to be successful financially. Like, yeah.
Yes.
And no one will actually directly say that to you, right? That it was actually a preventive cardiologist who's very respected at my institution, who I thought would be an ally, but he's kept his distance from me. But he did once, I mean, he's focused on like, my institution invented statins or whatever and PSK9 inhibitors, so they're obsessed with the medical therapy for prevention. And he said to me once, Jaclyn, do you really think they want you to stop the interventional cardiologist from being very busy? It's like, ouch, but he's not wrong, right? And they make so much money for a fee-for-service institution. But who does want less interventional cardiology? Our county system does. So how do I lean into what I'm doing over there and find solutions that work in that value-based system? And like the children's hospital, who knows where they land, because theoretically we don't want kids to be sick, right? And so how do you work within the financial system that is broken? Healthcare is broken in how it gets funded. So how do we just Band-Aid it by playing the game as it stands, which is fee for service in a lot of places? But I would argue that shared medical appointments also work very well in a value-based model. And also work very well in an ACO model. So you're building something with resiliency when you do it differently. And then it can hopefully withstand the changing tide of payer systems, which who knows where that will all go in the next decade.
They have your attention, please. We have completed.
We're not supposed to evacuate. Sounds reassuring. Okay.
Staff assistance, but for the
I work
ICU,
more with residents in, obesity medicine. Again, I had
Yeah.
to branch out because lifestyle was still not
A thing.
growing. So obesity medicine is the way I get my patients through the door and then talk about metabolic health, talk about smart goals and all the lifestyle things we do. And that has really helped me be successful both at the weight loss and metabolic health. My question is, again, my residents are medicine, family medicine, and now psychiatry is setting residents because food addiction and weight gain with cyclists is a concern. So I'm going to have some psych residents. How do we get the buy-in from the residency programs? They're coming for the obesity elective. They're really not coming thinking they're learning other things. Still, the residents have word of mouth discussion and choose to come for the elective. The program management itself has not had a buy-in from what I see.
So I'll come back to that in a second, but first thing I would say is you just put them in what you're already doing, right? So if you're running shared medical appointments, you try to get them at that. Let them see and ask for more. Because the learners themselves are a big part of it. And it does take a champion, but it really only takes one person with a little bit of influence. So most of the time it's the APDs, the associate program directors of fellowships and residencies that have been my in, and we don't advertise to anyone. I did not go out looking for residency programs. It just fell into my lap that they came to us, and it was because there was an integrative medicine trained APD in our family medicine residency. And so she just brought it up and said, every single one of our patients wants to talk about diet, whether it's a child check or an adult or anything in between. Why aren't we training our residents in this? Let's find something that checks the wellness box and the nutrition education box at the same time. So she pitched it to her department and they were like, yeah, okay, we'll try that. And then as soon as the pandemic hit, they stopped it. And the residents revolted and it got reinstated very quickly because the residents had already fallen in love with it. And so I don't think they'll ever take it away. It's like a hallmark, and they use it as a recruiting tool now from the other programs in the city. Like it's a competitive recruiting tool. Maybe y'all need to have a little healthy competition to generate support. Like who has culinary medicine in their residency programs?
Yeah, I was gonna say that when we recruited for allergy fellowship, that was probably like the #1 thing that people wanted to ask about is, oh, you do food as medicine, you do culinary medicine, I get to cook. Like I love this sort of aspect. I don't know what plans are for the CCHN, but I would love to see if maybe down the road, if we can do something together, because I mean, we're all struggling with the same stuff. And can we pull resources together to show the powers that be, like how impactful this could be? Robin and I had talked about this back in the day, like, could we do, either two kitchens going on at the same time with both Chef Rachel's at each location, or should we just do like stadium style? But it sounds like it might be nice to see what it actually looks like in person. Because you all have just been doing virtual, right?
Mine's 100% virtual, yeah. So that the FAME elective, it can be virtual. I actually took it as a participant with patients, but it can be hands-on as well.
So can I tell you a suggestion here with hands-on experience? Invite deans, department chairs, anybody in the system. I mean, they might just drop by, but if you can get stakeholders to show up to culinary medicine class and see the action. The other thing we did is we invited the entire marketing team for our university to come to a class as a team building exercise. They paid for it. We did the PR, we did the development team. So I just planted this as like an idea for team building. And then we started to go external, and we call them stakeholder classes. And we invite local chefs and growers and philanthropists, and they all just hang out together. And then guess what? One of the vice presidents met so-and-so at lunch, and they talked about my culinary medicine program. And now they're hearing about it from someone externally, and it suddenly has validity that it didn't have when I was talking about it.
What's the best time to do that?
Yeah.
Kind of class? Is it evening? Is it lunch?
Yeah.
Is it Saturday?
All of our it depends on the audience, right? So we've talked about learner timing, which varies. My student elective and my fellow classes are always start at 5. And then we run them 5 to 7:30, and then it's dinner time anyway, right? I'm donating that time, right? Actually, I started bringing my kids because my 10-year-old, who's my younger, was like, Mom, I'm good at cooking. Why can't I come to culinary medicine class? I'm like, I can't bring her to patient classes. But I thought this is perfect because we want this to be a family affair. We want to show what it's like when you are teaching this at an early stage. So I've started having some of my kids come sometimes. And then other residents and fellows will say, can my husband come? Can my wife come? Can I bring an older kid as well? And so it starts being more of a place that feels safe to interface with your personal life, right? We're not so separate about everything. So that's one thing to figure out with learner audiences. With community audiences, there's never a perfect time. So our patient classes, we run 3:30 to 5:30. So people can usually work most of their workday, and then I write them a note that they have medical appointments. With stakeholders, if it's a university team, they want it during business hours. They want their job to be paying them to come to this. But if you're doing external stakeholders, it depends. Like when we were building the church partnerships where we run our shared medical appointments, the pastors and all of their staff, they want it during business hours too, because we were inviting all the stakeholders for that. But then if we're doing it with philanthropists and other work, we got a bunch of lawyers in the city to come to one. And they loved it. And then all the law firms were like, can y'all do this as team building for us? I'm like, I don't actually have time for that, but that could be a good business model because they're willing to pay quite a lot for a team building with the lawyers. And so you start to see that everyone has fun. This is like sur la top cooking class plus nutrition and health. And so you add a whole new dimension that a traditional cooking experience that everybody tends to enjoy doesn't have. So they tend to want evening. So I think you just experiment with a little bit of everything and see who can come.
Now, you talked a little bit about school health.
Yeah.
Have you guys taken that to like a high school and invited families, patients?
Yeah, so not yet. We had a whole proposal in a high school on board pre-COVID. And we were ready to launch it almost like home ec 2.0 at a high school, and then lost the funding and the project with COVID. I would say that I've since started to insert myself into the local, it's like a committee of all the ISD nutrition staff. And I will say, generally speaking, they're very focused on meeting the USDA standards. And I said this also at Grand Rounds, but the school lunch program is funded by Congress because they buy USDA commodity crop leftovers. So a lot of the standards, even though they are improving, are contingent upon using these ultra processed foods. And so the funding would go away without it. So they're very particular about meeting USDA standards, and they don't have a lot of energy in most schools to go beyond that. So what I have leaned into instead is the school nurses. And we are really integrated now with the school nurses, and we give workshops and continuing education for them. And they are so interested, and they're learning for themselves. And then you can see that that's then going to hopefully trickle down and have a legacy effect on the kids they're talking to. I mean, think about it. School nurses are often screening for acanthosis, and they're, talking about, well, you have a tummy ache again. Let's talk about that. He might need to see you about that. And, and recognizing that there's a connection between food and emotion and trauma and access, and how can they pick up on these things, because our schools are really such a safety net. Hopefully we keep funding our schools. Yeah. Because that's up for grabs in Texas right now. Okay. Depressing.
Yeah.
And so I think you say, okay, that failed. I didn't fail. That just wasn't ready. What's a different way? Okay, the nurses want to talk to me. Let's go see about that. And so no, I have not figured out how to integrate into the schools. I think it would be amazing.
Yeah.
But South Carolina,
Yeah.
and Dr. Jaclyn Head is one of the people leading that.
And then there's other folks too, the chef that presented last.
Brigade.
Yeah, thank
Yeah.
you, Brigade,
I don't know his
from a
name.
culinary side have gone in and approached the schools and done some work
Yeah.
that way.
Because they often can bring in some resources. And the Culinary Institute of America just announced a master's degree in culinary therapeutics, where they're trying to train chefs in kind of the nutrition side, using food as medicine to get them, because so that chefs obviously want to be engaged.
And I know Dr. Robert Lustig, he's fighting it in California. He even trained himself and became a JD or something to fight the food companies and fight the whole food addiction and ultra-processed food system. It's fascinating what he's doing in the school systems there.
He is quite a character.
Yep.
And you know what? I think you have to also decide what your style is in solving these things. I am a 6 foot tall redhead from the South, so I'm obviously a bit much to people at times. And I just had to lean into the fact that, okay, I'm an assertive person who has a style, but I get a lot more done if I come and figure out the game and the rules and start playing by the rules, and then suggest an amendment to the rules, rather than completely going aggressive in the way that, a late career older man might be able to get away with. So you have to find where you can make progress without burning the bridges. And I would argue that while he's doing some really interesting, important work, he's also burned bridges in his strategy and approach. And so we all have to think about, how do we stay assertive and intentional and tied to the cause, while also hopefully capacity building and leaving space for everyone's voice and for nuance. Easier said than done, but it's all a work in progress. You learn the hard way, right? Fall down. And my favorite analogy for this work is, my husband's an outdoorsman, and he always says he doesn't go to Big Bend National Park, which, if you're not familiar with Texas, is all the way down on the US-Mexico border, because it's too paved. And he's like, it's too populated, too paved. I like the state park, which is actually only about 40 years old, and it's very rugged. It's got a retired volcano, and there's some hills in that park that no one's even hiked yet. And he comes home from these trips, and he's covered in bruises and scratches and bug bites and sunburn. And I thought, oh, that's what this is. We are in the state park, bushwhacking the trail, because it has not been bushwhacked yet. And so there's going to be some scars that come with that. And we could choose to be in the national park and have a more luxurious experience, or we could do what is uncharted but might change the game. And so I think that's when you remind yourself that it is hard. It is hard, and it's hard for everyone. And just because it's hard, it doesn't mean you're doing it wrong.
And at the end of the day, you had a much better experience.
He had way more fun.
Yeah.
Yeah, and you feel proud. It's a sense of like, wow, I really pushed myself. I did something unique. Yeah. So there's something to be said for that. None of us signed up for an easy life if we got into healthcare in the first place, right?
What's your opinion on food addiction, since you deal with culinary medicine, and how do you approach that?
So that is not my area of expertise. I will say that People use food to cope. We know that, and it creates a dopamine response, certain foods, particularly ultra processed, high sugar, high salt, high fat foods. We know it has a dopamine response. We know food has a behavioral component. I think sometimes people oversimplify it and lose some of the complexity and nuance there. We also know that the food industry, and actually have a friend who's in the business world and was at General Mills and left because she was starting to feel ethical constraints with the chemists that are hired in order to make food hyper palatable. So I tend to use the word hyper palatable rather than addiction, just because addiction is a complex term. And I also think we stigmatize addiction in our culture, and we just have to be very careful about how people receive. Even the term food is medicine upsets people. So how does we make sure the semantics don't get in the way of the progress? And I think addiction is a touchy term. So, thinking about people's use of food to cope, or what can they use instead? What are we treating? Are we treating deep anxiety that's being otherwise untreated? Are we treating emotional pain from trauma that no one's ever helped you through? I spent my first 5 years in practice on the pediatric side in our foster care center at our children's hospital, where we had an intersection of social work and psychology services and child development and pediatricians. And every single child that we saw was traumatized. They were all in child welfare custody. And I began to just acknowledge, okay, food, sleep, school, play, toileting, the 5 things that you hope if you have a child at home, they figure out how to do. And those are the 5 areas that are most disrupted with trauma. And so sometimes using food is a control mechanism because there was no other control in that child's experience. And so their weird eating behavior is entirely related to trauma that we haven't processed. Or it's more complex than that. I mean, and again, I'm sure you're the expert on this more than I am. And so if you have anything to add, please do. But I think,
Yeah, you're right on.
I think we just have to be really careful about labeling things also as a disease state when our culture makes the unhealthy choice the easy choice. And addiction is still like, it's your fault that you got yourself addicted to that, is still how we view addiction. And I think there's already enough stigma around food and obesity. So I don't favor using that term.
I liked your question, what's your relationship with food?
Yeah.
That gets a lot of that.
Well, people will tell you, like, I can't control myself with sugar. Okay, well, when do you find yourself craving? Can we identify that you're having a blood sugar crash maybe because of what you ate at lunch, and now you're tired and hungry and your body's telling you that that's going to give you the pick-me-up? Or is it because you're stressed and you've developed a Pavlovian response to a sugar treat when you're stressed? Can we break the cycle with something else? Just like when I get work with people to stop smoking, I tell them to keep smoking, but to stop smoking at the normal time first. Like, when do you smoke? Oh, I always smoke when I'm in the car on the way to work, and I always smoke when I'm on my lunch break, and I always smoke then. Okay, I want you to keep consuming tobacco, and then you're not going to do it at those times. You break the habit and the associations, and then the nicotine addiction falls away more easily once the actual behavioral habit. How do you get someone to exercise? You habits, I think Atomic Habits has a lot of interesting stuff in it around, like, how do you stack it with something you already do? You get someone to take their thyroid medicine, you put the pill next to the toothbrush because they brush their tooth every day. And so let's take the pill then, and then you didn't have to work so hard to change that behavior. Can you put your tennis shoes in the front seat of your car so you go to the gym on the way home? All of those, like, behavior change tactics. I think with food, we have to get to the root of the behavior, what it's serving, and help them develop other coping strategies. Same with alcohol, like dissociating it from the current behavior.
It reminds me of, we have to learn from our patients and learn from even the audience that we're probably teaching.
Yeah.
So, because I started teaching a plant-based pantry cooking with a transitional housing complex, where I just like invade their pantry and figure out what they're gonna eat that night. And so a lot of it is like, I'm learning from them. And one of the things that I kind of took away from the first few sessions that made me do an implicit bias check on myself was that there were a lot of vegetarians in that homeless population. So I wasn't really, I'm doing this like major life change for them. Like, they already eat vegetarian, and that's what I was cooking. And it was kind of surprising to
We
me.
thought it would be new to them. Yeah.
Yeah, so.
My dietitian always says, do not write other people's food stories for them. Like, don't assume everyone from Mexico likes this. You know, do not assume everyone from this culture eats rice. Do not assume the children will not like that. You know, and I think you have to sort of reset all of your expectations and then let everyone have their own story. And their story can be a quick transition, or it can be a very slow transition, but it's ultimately theirs. So as long as we really, I think in clinicians, we have trouble relinquishing control over someone else's autonomy and the management of their health. But ultimately, I'm not at their house. I'm not their guardian angel on their shoulder. They have to do this. So I need them to need less of me and figure out their own way forward. So less of me is the goal. And I think in healthcare, we have a hard time with that. But in the food space, that's the only thing that works, is letting them have the autonomy and carrying it forward. And I guess I will say one thing also back to the addiction topic. I do think disruption of microbiome from ultra-processed food is probably having neurohormonal effects that we're still learning about. People are studying that. I'm really curious what they learn. But then if you disrupt that by changing to a healthier microbiome through fermented foods, and I think everyone, it's a good thing to add fermented foods and then lots of sources of fiber, that you can change your microbiome. It's a dynamic thing. Yeah. And the links to even obesity and satiety and hunger, all very fascinating work. Yeah. Depression, anxiety. Oh, we have a depression and anxiety center who has stool from a huge population of patients, and they're beginning to look at microbiome and tie to mental health. Yeah.
More on like the specifics question, when your culinary medicine clinic, when the patients show up, is that a pretty low no-show rate for that compared to regular old clinic?
Yeah, pretty low. I would say, well, the last two clinics, absolutely everyone showed up, and I was kind of annoyed because it was a really busy, really full day, and I was kind of wishing for a no-show or two. Maybe one or two. If the weather's horrible or, something happens on the interstate, then we'll have some no-shows. But I think it's because they know it's going to be really hard to get another appointment.
Yeah.
Because they had to wait 4 to 6 months to get an appointment, and then they know they don't want to miss it. Yeah. And then that's who you want. You want to work with the motivated people. Like, we want to reach everyone, but you start with the people who are ready, because there are plenty of them. To your point, we think they might not be ready, but they're ready. Yeah.
But have you seen patterns that the private payers come more, or the Medicare, Medicaid?
We have all three. Now, could you sustain a program and its expenses on an entirely Medicaid population? You could not. So, but what we have been studied is, what do all the payers pay at the contracted rate? And the contracted rate of the charge for me as a primary care billing 99214, 99215 is 15% of the charge is the Medicaid contracted rate. Medicare pays 40% of the charge, and the private payers, our biggest one is Blue Cross, is 70 to 80% of the charge. So all of them pay at the contracted rate. But a payer mix has been essential for adequate reimbursement. I would say we have about 50% Medicare, in part because, who's my biggest patient? Retired or semi-retired women who are finally taking care of themselves because they have
the most
6 metabolic health conditions. They've been cooking and feeding everyone else and not paying any attention to their own health. And they're sort of having angst about their relationship with cooking and with food because they have been the feeder. And now it's like a reframe for their own health. And then they do have time, right? But I also have people down to about 25 in our cooking classes. We usually have 2 or 3 men in a class of 16. We do encourage partners coming. They have to both be patients. So, but spouses and domestic partners, if they are both patients, I'm like, we love having the family effect, because if you get both people on board, why are you making it your partner's job to feed you when you're the one with diabetes? And I have very frank conversations, particularly with men in Texas. Oh, so you have 6 problems and you want to change your diet, and you're blaming your wife who does all the cooking and shopping. you might have to learn how to do something here, you know, and I will just tell it to them straight, like and then come to culinary medicine class. We will help you overcome the barrier that you don't know how to cook as a 70-year-old man. But then we also get men whose wives die and they don't know how to do anything. And we are giving them microwave recipes at the beginning because that is all they can do. But that is better than, you know, McDonald's and Taco Bell, right? So almost any food prepared at home, less sodium, less saturated fat, less sugar. And so helping also our learners understand not letting perfection or some ideal be better than, be the enemy of doing better, where you can make progress. But I love, multicultural classes. There's some tension sometimes. Like one time we had a patient who disagreed with another patient on a spice. And she it was like, this is high school basketball. She booty slammed her out of the way and put her spices in. We had to relocate this other patient and kind of damage control her. And people bring their feelings to class. And I think that's part of the learning is that you don't have the monopoly on the answers in your food experience. Everybody's food experience is relevant. We have to share, and sometimes other people's food experiences make us uncomfortable, and then maybe we should look inward and figure out why. And so we have to process all of those things in group sessions, and which is also why I don't bring inexperienced learners to be in those sessions. I make sure they've had some training, and I think sometimes we bring our learners to service learning experiences without thinking through if they're equipped to manage it, because it's actually quite a bit harder than we give it credit for. And when you have lots of ages and diversity in ethnicity, age, cultural backgrounds, and payer mix. But I think that's part of the magic, because this class is in South Dallas, which is our traditionally redlined area. And so people who are coming from a different maybe payer mix or cultural background, they're having to commute now to this class that's convenient for the community that lives there. And I think that is another breaking down of the barriers, is that you had to drive out of your comfort zone to come to a church in South Dallas to take this class, but it mattered enough, so you're showing up. And so, I think lots of social and racial healing happen in a cooking class that we aren't even measuring. How do you even measure that?
I'm glad you made that in the grand rounds, or this morning you talked about the cooking class in the church kitchen, because those unutilized kitchens, even at schools have kitchens. Where they now
Probably
keep
also
things,
dormant,
but still, that they're largely dormant. My
Like
church-
home ec labs.
Yeah, if those exist, but yes.
Any school built in the 60s or
Yeah,
70s still
yeah.
has one of those,
They
right?
should, they should.
The
But-
new ones are putting it back.
Oh,
They are.
Yeah.
You're right. You're right. We're back. We're headed back. And like you talked about the library earlier.
Yes, the Green Hills Public Library up by the airport that's where I teach. It has 3 full professional kitchens. And it's a ginormous space, but yeah, so.
Yeah, there's a library in Philadelphia that's part of the Teaching Kitchen Collaborative called the Philadelphia Free Library, and they have a whole program funded for culinary literacy. And they teach people English and cooking at the same class, and so it's a unique way to integrate and help someone feel at home that might be a refugee or, from a different background than what, don't even know how to go to the grocery store in their new place and space. So I think food can be so healing for people in lots of different ways, but we have to continue to fight the fight of some of this is touchy-feely for the bean counters. So how do you make the case that it moves outcomes? I think that we're going to have that data in the next 5 to 7 years.
Another practical question I have is, if your patients suddenly have a URI or something and can't attend a live session, then do you give them the option of Zoom, or how?
So we have done that in a research context. Okay, one question: how far away are we from the airport?
Yeah, I think we probably have to wrap up
We-
in the
yes.
next couple of minutes.
I actually, I need to do that. Complicated. Zoom is complicated. I'm about to do another study, and this is going to be a very specific population of living kidney donors. So these are people who donated a kidney, and we are doing culinary medicine as a way to help them prevent complications, because most people who donate kidneys are overweight and have hypertension and at risk for metabolic health themselves. So we're integrating this, I was approached by the donor team to say, we're trying to offer more resources to our donors for staying well. And many of them, to meet the lab criteria to be able to donate, they're like on their best behavior for a short period of time. And then they're monitored for 2 years on the recipient's insurance. So we're able to track their health outcomes that are at no cost to them. And people universally gain weight, A1C goes up, lipids get out of hand, because it's almost like they fall off the wagon after they've donated their kidney. So we're going to do that on Zoom because many donors do not live in the area. They're coming in to donate to their relative or friend in the area. When I have done it in our county hospital context, we had both an English class and a Spanish class. Interestingly, very different culinary literacy in those two groups. Our Spanish speakers had much higher culinary literacy than our English speaker group. But a lot of them, despite extensive instructions in both English and Spanish, including a technical setup, did not know how to sign on to Zoom. They had trouble with it. They couldn't mute and unmute themselves. They were embarrassed about the fact that their dog's in the background or their kids are in the background. They thought it was a cooking show, not a cooking class. You know, we sent them gift cards and recipes to buy the ingredients, and you know, here's your grocery store list. Only about half of people actually did it. So I think it's you have to set them up for success, and it's an enormous amount of work to set them up for success.
Other populations might be, as you were talking about, that would be like military recruits or those in the reserves who like gear up really quickly to either go to boot camp or to pass their PT test and then fall out. Because 13% of the recruits can't make it through boot camp.
Yeah, and there's actually a lot of effort, I think, in the military right now to improve lifestyle support. Yeah, everyone needs it. Yeah. And in every season of life, you might be killing it and then something changes in your life and you are now struggling. And so I think if we all maintain that humility, that at any point we could fall off the wagon, even as people who are educated and resourced, that it's all about developing the resiliency to feel like you can get back up again.
When I was learning about teaching yoga to people with different abilities, one of the things that the person said was, we're all, most of us are temporarily able-bodied, because in the end, all of us will have some kind of disability, even if it's just age.
Yeah, or you have an unexpected surgery, or you have a new caregiving role. You know, I think we all have to be really humble about what's working for us right now might not always be working. Yeah. Well, you guys are great. I look forward to hearing about what's happening from my friends. And thanks for coming to hang out and for all the work that you do. I hope we can all stay in touch as we make progress.
Thanks for coming.
Yeah,
Really, it's a pleasure.
Thank you so much.